All right. Just get the chat. All right. So, um, we left off, we were talking about water balance. Oh, excuse me. So, you got to remember like water solute ratio is more important than trying to think of it as like, oh, what if we just raise water or lower water? Like if we think about my right hand's water, left hand is salt. If I increase sodium levels, that person's ratio is off. They are technically dehydrated. The, the salt level is too low. If I lower it, there's hyperhydration. The salt level is too low. Well, same thing. If I raise the water too high, hyperhydration. If I lower it, dehydration. Okay? So be mindful of that when you're thinking of this. All right? Um, so when we talk about hyperhydration, they're either consuming too much plain water, just too much water in general, and so we start to dilute it. It's a hypotonic solution, so the water follows the solute, so it goes into the cells. The cells swell. You have edema. This is where we see like what's called like pitting edema. So you'll push on the person and it'll leave like your fingerprint or your finger depression, and then after a while it'll come back out. We kind of experience this in general, this type of edema when you stand up all day. That's normal. There's nothing wrong with that. So here it's just too much water. It's going to enter into the cells, extracellular fluid, intracellular fluid. It's going to saturate all compartments. Okay. Um, Dehydration. So the problem with dehydration, typically we talk about like hypovolemic shock. It's low volume. So as water decreases, it'll leave the interstitial cellular compartments. If as we lose it from the extracellular compartment, it'll start leaving all the cells and shift out. Okay. ADH, we talked about this, so it helps us drink more and then helps us reabsorb through the aquaporins from the nephron back into our bloodstream. So we don't lose water by peeing it out. Electrolytes, they're going to be affected. So if when you look at like measurements, like blood measurements, for example, and a patient comes in, if they're extremely dehydrated, then what's going to happen is that levels will look high. If they're overhydrated, the levels will look low. So it can alter it as well. So hypernatremia, same thing we were talking about. Either there's too much sodium or too little water. Either will net you the result of hypernatremia. It's too much solute to the water ratio. Hyponatremia is the opposite. So there's too little salt to the water ratio. Okay. Or they're not intaking sodium, they're losing it for some reason, such as like with Lasix, sometimes they'll be hyponatremic. And so we'll tell them like consume a little more salt, or we give like salt tablets, stuff like that. You can't like correct salt levels aggressively. If they do, it becomes a problem. So when plasma is hyperhydrated, so too much water, the sodium level will appear low. So there's your hyponatremia. Too much water, sodium seems low. Okay? Too little water, sodium seems high. If sodium is too high, sodium's too high, hypernatremia. If sodium's too low, hyponatremia. All right? So you got to think of it in that aspect. You can't think of it just as, oh, we're altering just the electrolyte level. We also can do it by altering the water level. So when we start to like fluid overload patients, sometimes you can see that, right? So AMP, what does he do? That's a question for you guys. What does AMP do? Drive you crazy? AMP2 especially. What does atrial natriuretic peptide do for us? And then what does aldosterone do? So what's AMP do, and then what's aldosterone do? Come on, wake up. Stops reabsorption of sodium. So when we lose sodium, who's going to follow? Water. So one, we can see hyponatremia. The body's not going to do that, okay? Unless there's something like really wrong with, there's an excess secretion. But sodium levels will drop, and as sodium leaves the body, water will leave with it as well. So blood pressure will drop. And then aldosterone. What's aldosterone do for us? Oh, the pollen is kicking up, I tell you. What's aldosterone do for us? Come on, guys, you gotta be popping these out. Helps absorb sodium. So if we pull sodium in, we lose potassium. Okay, so remember that second part. Good point there, Jerry. So if we reabsorb sodium, we lose potassium. What happens to blood pressure? Water is going to follow sodium. Blood pressure is going to go up. Hyperkalemia, too much potassium. So same thing. If I drop the water too much, I see hyperkalemia. If I raise the potassium too much, I see hyperkalemia. Hypokalemia is low. So either I'm not enough potassium or I'm raising water too much. Hyperkalemia, the big thing, cardiac arrest. So this is, we talked about this in heart, but so if you remember, that's where we have this guy. And so potassium needs to leave the cell for the cell to repolarize. And so when there's too much potassium out here, it can't, it blocks it, and then the heart can go into cardiac arrest. Hypokalemia, you tend to see like muscle spasms with this. So one of the signs someone has hypokalemia is when you put a blood pressure cuff on them, they'll have carpal spasm. So their hand will just start doing this. That is a sign. Or you can tap on the facial nerve here, and their jaw will just spasm. That can be a sign that someone has hypokalemia. So aldosterone, we lose potassium. If we produce aldosterone, we pull sodium in, we lose potassium. Hyperkalemia, if it's high, the body will release aldosterone to correct it. So we'll pull sodium in, we'll get rid of potassium. If our potassium is low, we will stop producing aldosterone so we can release sodium and pull potassium in. So in DKA, there is a symporter in the intracellular cells of the body. Okay, in the cells of your body, when you have an acidosis point, so hydrogen ion is shifting out of the cells, potassium shifts out as well. So when these patients come in, we don't sit and correct their potassium level because we know it'll normalize if we correct the DKA. So we'll give them insulin and glucose. We'll drive the glucose into the cells. The hydrogen will retreat into the cells, and so will the potassium at that point. And then in alkalosis, we see the reverse. It has been driven into the cells. It is both of them. And so we see that alkalotic state. Hypercalcemia, same thing. Too much calcium, either too much calcium or too little water. Also here we can see this excitation of like muscles. Same thing with hypocalcemia. That can be a sign. So not only potassium, but calcium too. Tap on the facial nerve. We can see that result. So with all of these terms, you need to familiarize yourself because on a question on the exam, they could be like, this patient exhibits hypocalcemia, right? And so you need to be familiar with all the terms. Remember, hypo is below, hyper, lots of activity, it's high. PTH, parathyroid hormone. So when calcium is low in the bloodstream, we release PTH. And that pulls it from the bone, we pull it from the urine, we absorb it from the GI tract. We want to elevate blood levels. Calcitonin tones down calcium. When it's too high in the bloodstream, we send it back into the bone or we secrete it out of the body through the urine. So I remember it tones it down. So ADH, he's made by the hypothalamus. He's sensing osmolarity. Aldosterone, we just said this, adrenal gland. AMP, right atria. They say the heart here in general, but the right atria specifically. PTH is by parathyroid gland, and then calcitonin, the thyroid gland. Okay, so it's going to sample it directly and produce it. It's sampling our blood and producing it there. All right. So we talked about this as well. So acidity, that's when there's excess hydrogen ion. Remember, blood is 7.35 to 7.45. So if we go below that 7.35, that's acidosis. There's too much hydrogen ion floating around. Alkalosis is if we go above 7.45. So there's too little hydrogen ion floating around. Bicarb is bounded up or we've lost it. Situations you'll see alkalosis in is like when anorexia, or bulimia. Bulimics will vomit too much. Anorexics do it as well. And so they lose hydrogen ion from their stomach like crazy. So we can see it in that situation, for example. Go through the bicarb buffer system, protein buffer we talked about with blood, phosphate buffers. These are the 3 different buffers we focus on here. So all of these are trying to normalize the 7.35 to 7.45. So if we're above it, they'll release hydrogen ion. If we're below that range, they'll bind hydrogen ion. Okay. So protein buffer, it's the same way. It just amino acids are doing the job. So if the pH, lights just turned off in here. If the pH is too low, it'll bind hydrogen ion. If the pH is too high, it'll release hydrogen ion. It's not as strong as the bicarb buffer system. Like the bicarb is the best. Okay, it is the gold choice. All right, and then hemoglobin, same thing. It binds hydrogen ion. That's why we're able to breathe it out when it reaches our lungs. And we're picking it up from the tissue from doing cellular respiration. And then phosphate buffer, same thing. Binds hydrogen ion to increase pH, releases hydrogen ion to decrease pH. So acidosis, we talked about this, respiratory metabolic acidosis. So like if the respiratory system is not operating correctly, we build up hydrogen ion because we're not breathing it out. And then metabolic acidosis, if we're not peeing it out, it accumulates in the body. So either way, pH drops, there's too much hydrogen ion, and we need to correct it. Typically the other system, so whatever system isn't working, the other will try and correct it. So if respiratory isn't working, metabolic tries to correct it, and vice versa. So we ran through these. Respiratory acidosis. If I have an issue with my lungs and I can't breathe out the hydrogen ion, that higher CO2, that higher hydrogen ion in my body will decrease the pH. Eventually, my kidneys will try and respond and correct it by reabsorbing bicarb and by peeing out hydrogen ion. And the respiratory alkalosis, I'm hyperventilating, I'm breathing too fast, I'm breathing off too much hydrogen ion, I have hypocapnia, I have lower CO2, and my pH is high. Eventually, my body will try and get rid of bicarb, the metabolic system, and I'll hold on to hydrogen ion from the urinary system. So metabolic acidosis, loss of bicarb. So kidney failure, for example, because they can't get rid of hydrogen ion. Diarrhea. So we see this also with anorexia, bulimia, when they abuse laxatives. You can see it in that situation. And then ketoacidosis, this is only seen in diabetics. Type 1 for the most part. Some type 2s can do it. It's like 10% of the type 2 population can. And then hyperkalemia, which you would also see in DKA, diabetic ketoacidosis. And then metabolic alkalosis. So this is we're losing too much hydrogen ion. So like I said, vomiting, typically seen in your anorexics or bulimics, and then consuming excessive antacids, man, that takes some effort. All right, that would be like someone consuming, like, the big bottle of Tums. They're probably killing half of that a day or something, a quarter of it a day. It would take some effort there. And then hypokalemia. So if we like Lasix patients, that's where you're going to see that because they're peeing it out. We're inhibiting the reabsorption of it in the ascending loop of Henle. So respiratory with compensation. So if we're breathing too fast, we're losing hydrogen ion. The the metabolic compensation would be to hold on, or sorry, this one's talking about the other way around. So we have a metabolic acidosis. The respiratory is trying to compensate by hyperventilating. So in a diabetic patient, they are releasing from their cells too much hydrogen ion, too much potassium, and so the body responds by them breathing very rapidly to try and get rid of the hydrogen ion. What do you mean via what's the same as laser tattoo removal or not the same? You lost me. What do you mean? What's the connection with laser tattoo removal? I don't It's not a dumb question. I don't know what the connection would be there. I don't know that there's any effect on potassium with that. Typically what they're doing, they're like cooking, lasers can go different depths, so they're like cooking the ink out, like burning it out of you. Yeah, I don't think there's anything with potassium. All right. Urinary system. So it can get rid of hydrogen ion. It can hold on to hydrogen ion. The system's always trying to regulate everything in your body. It's always trying to maintain homeostasis. It doesn't matter what electrolyte you're looking at, hydrogen ion, oxygen levels, CO2 levels. Your body is always trying to maintain it. If one system fails, another tries to pick up the load. Okay? Tries to pick up the load. If it can, it will. So that's why you see a lot of times like people will come in and all of a sudden they're just like deathly ill and you're like, how'd you get to this point? Well, what happened is something started to fail, the other system started to try and pick it up, and then all of a sudden there's just collapse of everything. Right? Hyperkalemia is caused by metabolic acidosis. It's not really gonna cause a metabolic acidosis. It's a metabolic acidotic state. And really, DKA is your big one that's going to cause hyperkalemia. Outside of that, kind of tough. Okay. There are a couple diuretics on the market like spironolactone. They're potassium sparing. They work on the PCT. Those could increase potassium levels. So if a patient was strictly on that, yeah, we could kind of see that. But typically we use that drug um, when they are they're on Lasix and to maintain their potassium levels will stack in that spironolactone, the potassium um, diuretic to keep potassium levels where they need to be. And then hypokalemia. So this is a metabolic alkalosis. This would be like Lasix. Patient takes too much Lasix, or we're not correcting the potassium level. That's really where you're going to see that. All right. What questions do we have? Let's knock out some review. Oh, that's what, okay. That's where you're getting the laser from. No, when I say Lasix, I'm talking about loop diuretics. So LASIK is eye surgery, laser. LASIX, an S on the end, is loop diuretics. Sound alike, look alike. It'll get you all the time in the medical world. Telling you, you walk around the hospital, you'll hear everyone pronouncing azithromycin and erythromycin as azithromycin, erythromycin, so that no one confuses them. It happened to my dad actually once. He was on, was it dilazatam? No, diazepine. My dad's on diazepine, which is a calcium channel blocker for his heart, and they gave him dilazatam, which is a is it Prozac? No, it's one of them. It's one of those medications for like depression. My mom went to like she feels like the little like daily pill dispenser, and she went to fill it. And she's like, "This pill looks different," and she called my wife up, and she's like, "Can I send you this pill and you tell me what it is?" And I was like, "Oops, someone made a boo boo. That's a big boo boo. That is a major misfill error." So, what questions do we have? What are we stuck on? What do we need to go over? What's not filled out in the lecture notes? Let's see. Just want to peek at our schedule just to make sure I'm on track with everything. Sometimes, you just have a brain fart. Today is 20th? Yeah. Yeah. So Monday we won't meet. Wednesday is exam, so a week from today. If you guys don't have questions, just go study then. Unless you're flipping through frantically trying to find something, that's fine. Find something. Yeah. So, whenever you talk about left shift versus right shift, left shift, you got to think the tissue isn't working. So, if it's not working, it doesn't really take oxygen away. Whereas right shift, the tissue is actively working, so it takes oxygen away from the hemoglobin. So it unloads it very rapidly. Why is it not sharing? Share. There it goes. So, whoops. Trying to minimize this so I can see. So here, the blue is normal. When the body isn't really working, it doesn't need to unload very rapidly. It's not taking oxygen away. Whereas when your body is really working, high temp stuff like that, we start to unload it much more aggressively. Same thing with uh, like pH. If we're working, we're generating hydrogen ion, so we unload it earlier. Versus if we're not working, we're more alkalotic, then we unload later or less aggressively. So I always think like if it's a right shift, body is working. If it's a left shift, I'm sleeping. That's how I think of it. I'm not active. So you could think like right shift, sympathetic, left shift, parasympathetic. So that's why we do like targeted temperature therapy with patients. Like after an MI, we'll lower their body temperature so that their demand for oxygen is lower because cellular respiration decreases and they can recover much better. So, Erica, that's going to be what we were just going through. So, like the hypothalamus making, um, well, hypothalamus making ADH isn't really one. Adrenal gland making aldosterone, for example. So, when the adrenal gland makes aldosterone, we pull back in sodium and we get rid of potassium. Calcitoparathyroid making PTH, the thyroid making calcitonin. That's what they're looking for there. And then for water balance, just straight water balance is hypothalamus making ADH. And then right atria of the heart making AMP to decrease water and sodium. Welcome. Y'all gonna crush this test. You got a week to study. Y'all better crush this test. I want no excuses. Come on, we gotta beat the other classes. I got a rep to keep here. Right. So the partial pressures. So with this, you gotta always think about where you're at. So here, when we're at the lung, we have low O2 because we've passed by the tissues. We have high CO2 because we've passed by the tissues. We've picked that up. The alveoli, because we're breathing air from the outside, has very high O2, very low CO2. So because of this, we're relying on gradients. Oxygen will rush in, CO2 will rush out. And so what we see on the backside of the alveoli or the lungs is we should have full saturation of O2 and full desaturation of CO2. Then we see the vice versa at the tissue. We have high oxygen coming in, low CO2. We have low O2, high CO2. Because of gradients, O2 should rush in, CO2 should rush out. And on the back side of that, we should see low O2, high CO2, and we loop back to lungs. So if PO2 was low, you couldn't push like if alveolar PO2 or atmospheric PO2 is low, then you couldn't push O2 into your body and you couldn't push out CO2 if it was high. So in that situation, it's like putting a bag over someone's head or they're drowning. That's what you're starting to talk about there. The lungs are obstructed. They have asthma. That's what's going to happen. That's the situation that's going to lead to that. Welcome. There could be. There could be because we went over like alveolar ventilation rates. Yeah, there could be. So I'll bring calculators. I'll bring calculators for you guys. It does, Bia, but also at the tissue. You're saying in the alveoli, right? Yeah, that's what I figured. Yes, and also at the tissue. So both these images that I have up right now, that's what they're depicting. So either point. But if you're talking about like straight lungs, like if they're asking where in the lung tissue does it happen, only the alveoli, because that's the only membrane that has simple squamous and allows that diffusion. So the rest of mouth all the way down to alveoli, before alveoli, to bronchioles, no gas exchange, only at the alveoli. No problem. Which calculations? The like for respiratory? Let me see where that was. Whoops, button. Let's see. Where was that? Why can I not find it now? Ah, there we go. So, tidal volume is how much we're breathing regular. So typically we say it's about 500 mLs. And then minute volume of respiration is how much are we breathing in and out of our mouth, essentially, is what we're asking. So if we're saying 500 is a normal breath, and we're saying this person has 12 breaths per minute, we just multiply the two. It should be 6,000 mLs or 6 liters. They're converting it over. Then, when we're talking about going down to the lungs, so we're going to talk about AVR, alveolar. I would accept either, Bia. But if it's like a multiple choice question, you're going to have to convert. So be mindful of that. But a short answer, I would accept either. Um, so when we're talking about down at the alveolus, we need to get rid of that place where there's no oxygen exchange, the conducting zone. So we say that's about 150 mLs. So we take what you're breathing in at your mouth, the 500, minus 150. So that gives us 350. We do 350 times the amount of respirations, and that's going to give us, where is it? 4.2 liters or 4,200 mLs. Welcome. Any other questions? It's going to be so nice today and tomorrow, minus the pollen that's starting. I think I've got to cut the grass already. I'm not looking forward to that. Mm. Mm-mm. We'll call it exercise. How about that? No more questions? If not, I will see y'all Wednesday next week. Anyone else? Anything else? No Monday, because we're done. We did review today, so we're ahead. So take Monday, sit down, study. Yeah, we'll have lab if you're in my lab, but no lecture. Good opportunity to study, 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 study. So you have 7 days to go through the material. Yeah, I will. I will be. Recovery. Let me look at our schedule. I just want to see something. Respiratory, urinary, fluid and electrolytes. Fluid and electrolytes, you really don't need to spend too much time on. We've been covering it. It's smaller chapters. 7 days to go through 3 chapters. That's more than enough. Crush it, my people. All right, guys. I'll see some of you in lab Monday, and then the rest of you, everyone, I'll see Wednesday for the exam. Bye.